This voiceover is going to concern itself with seizures and epilepsy. Now, the learning objectives are to describe the classifications of seizure activity, to identify therapeutic interventions to promote well-being in persons experiencing seizures, to identify therapeutic interventions in persons experiencing status epilepticus, and identify adaptive problems in individuals experiencing seizures. Now, a seizure is a clinical presentation of unprovoked, abnormal neuronal discharges in the central nervous system. Approximately 10% of the population will experience a seizure in their lifetime. The risk is about 1% from birth till age 20, and about 3% of those 70 years and older. Anyone can have a seizure given the right circumstances of central nervous system imbalance. Now, epilepsy is a recurrent illness characterized by at least 2 seizures. Primary means there are no known factors that lead to recurrent seizures, where secondary causes are seizures due to underlying disease processes such as a brain tumor. Now, you can see there's a whole list of causes of seizures, and I'm going to move to the next slide and have something to say about all of them. In young adults, seizures are usually caused by trauma, alcohol withdrawal, illicit drug use, or brain tumors. In adults 35 years and older, the causes are cardiovascular diseases, brain tumors, alcohol withdrawal, electrolyte imbalances, and Alzheimer's disease. However, about 70% of all cases still have no known cause. Now, characteristics of seizure activity can help the physician localize the area in the brain where the seizure activity is occurring. In temporal lobe seizures, there are psychic syndromes, such as hallucinations, motionless stares, epigastric pain, confusion, aphasia, and unilateral facial twitching or belching. Frontal lobe seizures exhibit themselves by kicking, thrashing, head and eye aversion to the contralateral side, posturing body movements, and drop attacks. Parietal lobe seizures involve vertigo, nausea, numbness, upper limb tonic posturing, tingling sensations, and loss of body awareness, where occipital lobe seizures involve blurred vision, eye blinking, visual hallucinations, and nystagmus. Now, to diagnose a seizure or epilepsy, you have to rule out certain things, including syncope, sleep disorders, hypoglycemia, transient ischemic attacks, movement disorders, and psychiatric illnesses. Evaluation is through history and physicals, exams, and details on the seizure activity itself. There will be EEG and neuroimaging done, such as an MRI, and possibly cortical mapping. Now, diagnosis is difficult because many times an extensive search for the underlying etiology will yield negative results. The diagnosis is made after ruling out other possible causes, and the clinical presentation and EEG findings help classify the particular type of epilepsy. Accurate diagnosis of the seizure type is important because selection of appropriate drug therapy is seizure specific. For example, some anti-seizure meds, if given to the wrong type of seizure, will actually increase the seizure activity. I want to look at the phases of a seizure. There are pre-ictal, ictal, and post-ictal. In the pre-ictal phase, the patient may have an aura, which is a premonitory sensation or warning that the patient remembers. It may be taste, visual, auditory, or something visceral. Examples include metallic taste, flashing lights, and is usually the same each time. The ictus is the actual seizure itself. And post-ictal is the period immediately after the seizure where the patient becomes very tired and usually sleeps for several hours. Now, there are many different types of seizure classification. Partial involves only one hemisphere of the brain. And simple partial is a rhythmic twitching of one side or part of the body opposite of the side with the seizure activity. Complex partial, also known as temporal lobe epilepsy, an aura is common. There is a loss of awareness, and they are spaced out or may have automatisms such as lip smacking or picking at things. Other terms involved in classification are generalized, and that involves both hemispheres of the brain. Absence or petit mal, which are blank stares that last about 10 seconds. Myoclonic, there's single abrupt muscle contractions. Clonic is jerking. Tonic is stiff. And tonic-clonic used to be called grand mal seizures, usually last 1 to 3 minutes. And then there's atonic, which are drop attacks. Furthermore, there may be unclassified seizures due to inadequate or incomplete data, and some that just defy classification. You realize that seizures may start with one type and progress to another. So I'm going to describe what happens in a tonic-clonic seizure so you understand more about the nature of seizures. Tonic-clonic seizures progress through distinct phases. The first phase is classified as prodromal. It's a period of irritability and tension which may precede the seizure by several hours or days. Some have an aura, and some the seizure comes without warning. Characteristically, a tonic-clonic seizure begins with a sudden loss of consciousness. Then there's phase 2, or the tonic phase. There's a major contraction of the voluntary muscles, so the body stiffens with legs and arms extended. If the person is standing, the person falls to the ground. The jaw snaps shut and the tongue may be bitten. There may be a shrill cry, and the person is incontinent of urine and possibly bowel. Apnea occurs but lasts only a few seconds, and the patient may be pale and dusky. Phase 3 is the clonic phase. It's violent rhythmic muscle contractions with hyperventilation, and the face is contorted, the eyes roll back, and there's frothing from the mouth with profuse sweating. Finally, there is the fourth phase, or the post-ictal. The jerking gradually subsides, the extremities are limp, breathing is quiet, and the pupils are reactive to light. Most patients awake but are confused and do not remember the event. They may have a headache, generalized achiness, and tachycardia. For the patients in the community, treatment of seizures includes treatment of any underlying conditions and avoidance of triggers such as fatigue, sleep deprivation, hypoglycemia, emotional stress, febrile illness, and alcohol. And then they will be given anti-epileptic drugs, or they may even need surgery, and we're going to discuss the drugs in a minute. They'll also need management of the psychological and social issues related to seizures. Now, what we're going to concern ourselves with in this course is status epilepticus. This is a seizure for 30 minutes or longer, no matter what the type. Tonic-clonic seizures that go into status have about 10% mortality, and stopping the medication is the most common cause of status epilepticus. Other causes may include alcohol withdrawal or withdrawal from sedatives or a fever. It is a medical emergency. There is cardiorespiratory dysfunction, hyperthermia, and metabolic imbalances that lead to cerebral ischemia and death. Now, treatment of status epilepticus, the goal is to stop the seizure and maintain the airway. Per physician's order, you're going to give Ativan 1 to 2 milligrams IV push, or Valium 2 to 5 milligrams IV push, which may be repeated if the seizure doesn't stop. They also may need paralytic agents such as pancuronium, and they may need to be intubated and then loaded with Dilantin. We're going to talk about Dilantin extensively in another slide. You're going to want to position the patient to avoid aspiration. And in this case of status, you'll want to try to get a soft plastic airway if you can get it in without forcing the teeth apart. In just a seizure that occurs that's not status, you shouldn't put anything in the mouth. You're going to want to suction the airway for patency, and oxygen can be delivered by a nasal cannula. You want to obviously do vital signs, secure an IV access, and monitor their neurostatus as best you can. Acidosis will correct itself after the seizures stop, and you're going to want to monitor their glucose because they will be hyperglycemic followed by hypoglycemia, which may require you to give D50 IV push. You want to treat the hyperthermia with possible cooling blankets. Now the Ativan IV, what you have to remember is it can cause respiratory depression or arrest. So it must be diluted with an equal amount of 0.9 normal saline and then given slowly. Now other pharmacologic agents include Tegretol, which will be 200 to 300 milligrams 4 times a day. The problem with that is rash, drowsiness, nausea and vomiting, and cognitive dysfunction. It's used for partial and tonic-clonic seizures. Clonazepam or Klonopin, 0.5 milligrams 3 times a day, can be given, but the side effects of that are drowsiness, ataxia, and behavioral disturbances. And that's used for complex partial and tonic seizures. Other anti-seizure medications are this following list: Serontin, Felbutol, Neurontin, Lamictal, phenobarbital, Misaline, and Depakote. Now, Dilantin should be given no faster than 50 milligrams per minute, or you may have bradycardia, cardiac arrest, respiratory arrest, hypotension, or VFib. Now, it's given only with 0.9 normal saline. If you shoot it into a line with D5W in it, it will precipitate. It's very irritating, so you need to watch the IV site, and may cause ataxia, drowsiness, gingival hyperplasia, nystagmus, or a skin rash. You want to monitor the serum levels of this. They should be between 10 and 20 micrograms per milliliter. And toxicity occurs with greater than 20 micrograms per milliliter, and the first sign is usually nystagmus. You need to monitor blood pressure, heart rate, and vital signs while you're infusing this drug. What not to do during a seizure. Now these are for seizures in general, not status epilepticus. Do not put anything into a patient's mouth. And again, I say the only exception is status epilepticus. Do not restrain convulsing limbs, and do not try to give the patient medications or liquids by mouth. What to do during a seizure? First, put on the call light, and then if the patient is seated when a major seizure occurs, ease him or her to the floor if possible. You want to provide privacy by pulling the bed curtains or screen or closing the door. If the patient experiences an aura, have him or her lie down to prevent injury that might occur from falling to the floor. Remove the patient's eyeglasses and loosen any constrictive clothing. Do not force anything into the mouth. Guide the movements to prevent injuries and do not try to restrain the patient, and stay with them throughout the seizure to ensure safety. After the seizure, position the patient on the side to facilitate drainage of secretions. You want to provide for adequate ventilation by maintaining a patent airway, and suctioning may be necessary to prevent aspiration. Allow the patient to sleep. On awakening, orient them because they're probably going to be amnesic about the event. As far as nursing assessment goes, the physician is going to want to know whether the seizure was witnessed or not witnessed, if there were any warning signs or an aura, where did the seizure begin on the body and how did it proceed, what type of movement was noted and what parts of the body were involved, were there any changes in the size of the pupils or was there a conjugate gaze deviation, what was the duration of the entire attack and of each phase, was the patient unconscious throughout the seizure, was there urinary or bowel incontinence, what was the person's behavior after the seizure, was there any weakness or paralysis of the extremities after the seizure, were there any injuries noted, and did the patient sleep after the seizure and how long. Each of these assessments are going to help them in determining what is causing the seizure or if it was a seizure at all. Now, as far as teaching goes for your patient, you're going to want to tell them to obviously eat a well-balanced diet, as we tell every patient, but eat on a routine schedule and avoid excesses of sugar, caffeine, or any other food that may trigger seizures. You'll want to tell them to discuss alcohol consumption with their doctor. If they choose to drink, they should limit their consumption to whatever the physician recommends. Seizures may be precipitated by alcohol consumption, and even small amounts can trigger a seizure in some people. As far as their general health, to avoid constipation, excessive fatigue, hyperventilation, and stress, because those may be seizure triggers. Regular exercise is good, but avoiding over-fatigue and hyperventilation. And also tell them to avoid exercise in hot weather. They should exercise in a climate-controlled environment. They also should have regular sleep patterns and take showers rather than tub baths. They need to do good oral hygiene and have periodic visits with the dentist because of the risk of gingival hyperplasia. As far as illness goes, fever can trigger seizures, so that must be treated, and any prescription or over-the-counter drugs should be reviewed for interactions. And if antibiotics are ordered, you should have the physician look for interactions with their medications for obviously prescribing them. Noisy environments should be avoided, along with bright flashing lights, fluorescent lights, strobe lights, a flickering television, and flashing bulbs on signs or Christmas trees. Tinted glass can be put on windshields of cars and eyeglasses that will help control glare. And you should advise them to use a screen filter over the computer to control glare from that. Educate them not to use recreational or street drugs, and work or recreational activities that could cause injury if a seizure occurred should be avoided. They need to swim with a buddy and avoid contact sports. Also, emotional stress can be a trigger to seizures, and counseling may be helpful in the event that they become emotionally stressed. As far as women's health goes, there may be an increased seizure around the time of the menses, and if they do occur around that time, the patient needs to control other triggers that may trigger their seizures. Also, they need to know that their anti-epileptic drugs may decrease the effectiveness of oral contraceptives, so therefore intrauterine devices or other contraceptive devices may be preferred. And seizure pattern often changes during pregnancy, so they need to discuss that with their doctor. And some anti-epileptic drugs can cause birth defects. Now, a big part of teaching for patients with epilepsy are related to drug therapy. The patient must be told that the drug has to be taken as ordered to maintain a therapeutic blood level, even if there's no seizure activity. These drugs may be necessary for a few years or longer, and for some patients, they may be necessary for a lifetime. And there are criteria for when and how a trial of drug discontinuation should be managed, and that needs to be discussed with the healthcare provider. Discontinuation of drugs without the knowledge of the healthcare provider is the most common cause of seizure activity. The patients also must know the signs of toxicity of the drugs prescribed, and that these symptoms need to be reported promptly to the physician. The patient should keep drug and seizure charts, and because there are serious side effects from some drugs, be sure that they have their blood work done as ordered. A medic alert bracelet should also be worn by the patient, and they must need to follow up on appointments with their healthcare provider for periodic monitoring and reevaluation. So that ends our lecture on seizures.